Looks good.
Cool, thank you. Okay, so my talk is quite different to Nat's. I'm going to give a talk today about mediation and conflict resolution and some thoughts I have about this from my experience in the area, I guess how I apply it to my work in critical care medicine. I was asked to give a talk on this topic because of my background in the field. Before I did medicine, I did undergraduate study in political science and psychology. After this, I spent a few years working for the Queensland Department of Justice for their community mediation service. I was a case manager and a mediator with this service. We handled a wide variety of disputes. We looked after workplace conflict. We looked after relationship breakdowns, family disputes, neighbour disputes. We did some really large community facilitations, Indigenous disputes as well. So it was a really fascinating job to have for a couple of years. And all I dealt with was conflict in this time. This is my old workplace here, notorious at the time for being Brisbane's premier illegal skateboarding site on account of this very controversial structure which is really polarising in Brisbane. So today what I wanted to do was talk about mediation as a process that can be useful for us in health because we often end up facilitating difficult conversations between people in our teams. And then I'd also briefly talk about how I personally think about conflict management, having worked in conflict resolution for a while. Okay, so just obviously conflict management is a really important non-technical skill in pre-hospital medicine and in critical care. And this is reflected in the literature and also in our DipPharm curriculum, so it's mentioned several times there. For obvious reasons, conflict is more common in the critical care environment and because we work in a high acuity setting. So issues can relate to patient factors relating to urgency, critical illness, high workloads, the presence of shift work. We work in teams, we work with different professional backgrounds that have to interact quickly in ad hoc teams, and that can be quite challenging. We obviously work in groups that are made up of diverse individuals in quite challenging situations. We might have to interact with people in conflict that have different value systems, different experiences, and different personality variables. So just a little bit on the topic of conflict itself. So this is a definition of conflict here, quite a basic one. And I want to stress that conflict is, of course, a completely normal process in workplaces and in other interactions. It can be both problematic and also very productive, depending on how it's been managed. So sometimes conflict in workplaces particularly can result in innovative ideas and system change if we constructively manage it. There's a reasonable amount of research looking at conflict in the emergency medicine literature, and they've described things that exacerbate conflict in critical care being unsurprisingly stressful clinical situations, the presence of ambiguity in roles, overlapping roles, when people have a lack of clarity about what their scope of practice is in a situation, when we receive pressure from others and we're trying to make a decision. Different conflict management styles obviously are more prone to conflict. And then importantly, conflict in health is often driven by external issues that are completely out of our control, to do with resource allocation and staffing. So this is obviously really important to acknowledge. So the reason why this is important is, of course, because conflict is distressing and it affects patient care. Even last week there was a review published looking at a review of articles about rudeness and negative behaviour in the healthcare setting. And overall, unacceptable behaviour negatively affects clinical performance in healthcare workers. It affects the quality of care we provide. It affects productivity and, of course, patient outcomes. So it's a really important area. So then thinking about the field of conflict management, it hasn't been extensively studied in the healthcare sector. It's a field of research that came to prominence during the Cold War, and it was quite prominent in psychology, political science and sociology. And so most models of conflict management have come from diplomacy in the business sector and is increasingly being applied to healthcare, which we're starting to see in some of our literature. This is a really sort of basic model of conflict management styles. It's called the Thomas Kilmann conflict model, and it's quite commonly cited. It was developed in the 70s, and traditionally it was an inventory of about 30 statements that people would go through to be classed into a particular conflict management style. Now it's just commonly cited as a broad example about how people can respond to conflict in different ways. The idea is that people often respond in a consistent way, depending on the sort of personality variables of assertiveness and cooperativeness. But obviously we need to acknowledge that one person might handle conflict differently depending on the context. So we're often different, say, in the workplace than we are at home. So unsurprisingly, if you have a person that is very assertive and very uncooperative, they're going to be a more challenging person to engage in a difficult conversation or a conflict with. So this conflict style is associated with more conflict. There's been some ED literature looking at different conflict management styles according to this model. And unsurprisingly, people that have a collaborative or a compromising conflict style work best in critical care teams. And so I think in our context, that makes a lot of sense. We want to be assertive enough to, I guess, advocate for our patients and what needs to be done in our clinical setting, but also be cooperative because we have to work in big teams. The reason why I bring this up is that obviously it's quite a simplistic model, but it does highlight that we all have a disposition in how we engage in conflict, and I think it's important to think about that. And it's certainly something that we tried to do with people before they entered a mediation process. So I'll talk now about the actual process of mediation. Mediation is just one form of alternative dispute resolution on a spectrum of different models. Of these formal dispute resolution processes, it's one of the least formal and binding processes. What it refers to is a structured process where a neutral third party, being a mediator, help people in conflict explore the problem and negotiate a mutually acceptable agreement. So I'm referring here to formal mediation. This is generally used for conflicts that are both significant enough and have escalated to a point that they need some assistance. But I want to note that mediation skills are often applied in a wide variety of situations, both formally and informally. Effectively, it's a structured application of good conflict management principles, and I think understanding this process can improve our conflict management skills generally, but it's also a good process to understand, like I said earlier, should you find yourself assisting others in conflict. And I know certainly in my role, I feel like there's skills that I draw upon quite often. I'm often the duty anaesthetist at my hospital, and I often find myself facilitating many challenging conversations between various teams around issues to do with operating theatre demand and other problems on the floor. So to talk through the principles of the process are important, and the fact that there are several requirements for mediation means that it's not suitable for all types of dispute. Very importantly is neutrality. So neutrality of the mediator, but then also of the location and the time being equally agreeable to both parties. Neutrality of a mediator is something that really distinguishes a formal process from when we would be intervening in a conflict as clinical leaders, because we're not going to be truly neutral in that situation. So that is one of the particular advantages of using external services when there is conflict. The service I worked for had very strict legal boundaries around confidentiality, so we could only disclose anything from a session if it was a risk to somebody, if there was a declared risk to somebody. Participants had to voluntarily participate in our process, but obviously this is variable. There are situations where people are compelled to participate in mediation. Unfortunately, this compromises it a little bit because it takes away an element of good faith if people don't truly choose to be there. We need parties to have a willingness to negotiate, because mediation is founded on trying to find a novel solution and common ground. So they have to demonstrate that they're willing to accept an alternative outcome. And then we need to make sure we keep people safe, and this is done by considering power imbalances. We need to make sure there's no significant power imbalances before we bring people together to have direct discussions. So this includes, we'd be particularly concerned about a history of violence in relationships. So this process itself can be applied to healthcare disputes. There is some evolving research about this, and we have difficult clinical situations involving patient care. So if there's complex clinical decision making where there's disagreement between the best course of action for a patient, or complex ethical issues. And this is an adapted mediation process, because again, it's not a truly neutral process, because we need to incorporate a patient focus here and keep the patient's interests central to discussion. This is a brief overview of the mediation process itself that we applied at my service. So preparation is really essential. It forms the groundwork for the session, and this is where most of the work was done. So the mediation session itself would be half a day to a day, but the preparation would be days, weeks to months, depending on the complexity of the problem. We would spend time with people providing basic coaching and communication skills, working through their story to help them identify their issues and their interests, to help them try to think about different alternatives for resolution. We start to begin a process of reality testing different options being put forward by parties to make this an easier process on the day, and would be assessing the suitability of the dispute for mediation. One of the really challenging things to do at this point was to get them to actually agree on a date and a time to meet. Often when we had very entrenched conflict, people would become fixated on not giving in to the other person. So even achieving a small victory like this, getting them to agree on somewhere to meet, would be a big deal in some cases. There is evidence that if you're in a protracted conflict, getting someone to agree on something small can help in the process of getting them to agree on something larger. And so we would acknowledge this with the parties. So this is the general process on the day. There's many different versions of this, but they generally follow this kind of model. We would start the day with an introduction to the process and would lay very clear ground rules about communication and how it was going to go and what would terminate a mediation. We would invite parties to make an opening statement. This is the opportunity for each of them to give their individual perspective or their story to the other person. From this, the mediator tries to identify common issues and themes from the statements to identify what points would need to be worked through to reach a resolution. And this is similar to when we as clinicians form an issues list. We take a larger problem and break it down into manageable parts to work through. So this makes the conflict seem less overwhelming to the parties, and it creates potential to agree on some things, if not everything. From this, we form an agenda and we ask the parties again to agree on this. This is another small agreement that we're getting them to make in the interest of a larger one. The next part is the bulk of the mediation, and this is a facilitated discussion guided by the mediator through each of the issues on the list. The mediator would ask probing questions to each party to explore their issue, but we ask them to direct their responses to each other. We continually remind them of that because it's their conversation. We use a lot of paraphrasing of what they say in guiding the conversation to keep the discussion constructive and on topic. The aim is, of course, to balance conversation. We want to ensure equal time to each party. We want to moderate the effect of different conflict management styles and enforce good communication practices that I'll outline on a later slide. During the exploration of these items, we're starting to explore different options for resolution. And I'll talk a little bit more about this later, but the approach we take in probing and guiding the discussion is that of a curiosity approach to their perspective. The next step is to have a private session with each of the parties to check in on them and make sure the process is still in their best interests, and whether they have any particular concerns about what's happening. We would start to explore options for resolution, and then if everything's okay, we bring them back together and try to reach an agreement. The agreements that we reached were non-binding for the service I worked for, but they could be registered with the courts. Sometimes the process failed in the sense that we didn't reach an agreement, but we didn't really see that as a failure. It wasn't uncommon to reach a partial agreement on some issues, and this goes back to the benefit of deconstructing the problem into something small, into smaller parts that you may be able to reach partial agreements on. Also, the process is beneficial even if people don't agree on the day. So there's a mediation saying that the process is part of the product, and this refers to the value of having a discussion and at least understanding the perspective of the other person. So this would create improved lines of communication between parties, and we often heard that they had resolved the issue independently with time. I'm going to talk just quickly about some of the skills, a few skills that we used in mediation, and I'll highlight that these are all basic communication skills that most of you would have heard of. It's nothing particularly magical, but they were things that we applied consistently and well due to rehearsal and experience. So active listening techniques are techniques that demonstrate full engagement and attentiveness to another person by attending to both verbal and non-verbal cues. These can be very powerful for people in conflict to feel that their perspective has been heard, and the impact of of the conflict on them has been acknowledged. These techniques were developed for counselling practices, and ideally it reframed listening as active rather than a passive process. I won't go on about this because we've been taught about this a lot in our training. I know it often feels forced to people, I hear that a bit, but like with any skill, it does become automatic when you do it enough, and I certainly found that. One that I will highlight that's a bit unusual to some people and is quite a mediation practice is a roundup. Rather than just being a direct paraphrase of something that's been said, this is more of a synthesis. So we would do this at the end of a discussion point. We would try to provide a summary of the experiences and the interests of both parties and bring it together and try to seek their agreement that we had a correct understanding there. So again, a lot of this process is about continually getting agreement from people. And in order to practice active listening, the way that it was taught to me as a mediator was to engage with people by acting with a genuine curiosity about their perspective, their experience and their ideas. This is that curiosity approach that I was talking about before. We needed to facilitate constructive communication between parties, and we're very vigilant about enforcing these expectations. These are based on, again, some basic and established conflict management principles. We encourage parties to make statements that avoided making assumptions about the intentions, attributes or characters of the other person. We have several cognitive biases that operate within all of us that affect how we perceive each other in conflict. And so a commonly cited one, and I've heard it discussed in a few contexts around here, is the correspondence bias or the fundamental attribution error. This refers to an individual's tendency to attribute another's action to their character or personality whilst attributing your own behaviour to external factors that are out of your control. It's represented up here on the screen. We would take time and acknowledge the emotional impact of conflict. That was an important part of the process. But we would try to avoid blame and misattribution by trying to keep the discussion focused on facts and issues and interests rather than talking about motivations. And an important technique that we would utilise in trying to enforce all of this was reframing. So the mediator would rephrase an assertion that was made by a party in a more constructive way that removes the blame statement. And when we're doing this, we would remind the party of why we're doing this. Lastly, we used a lot of reality testing in trying to encourage the parties to adapt their expectations to the reality of the situation. Reality testing is just a questioning style used to address entrenched positions and encourage people to think about alternatives, the challenges that are associated with their current fixed position, and hopefully reframe their expectations. Obviously, it's important this is done very fairly if you're facilitating a discussion between people. You don't want to feel that you're excessively challenging one person. But this is a very useful process to help get people into a mindset for negotiation. So just to bring it together to think about why this process works. Importantly, it creates the opportunity for shared perspective taking. So people are very, very commonly not aware of all the facts from the other person's perspective. And they're very commonly not aware of the potential issues or drivers of the conflict for the other person. So having this opportunity to hear from the other person allows them to see behind their actions and hopefully understand their context, their situation, their intention, and this helps to challenge those pre-existing cognitive biases that exist. Very importantly, a shift from positions to interests-based thinking is a fundamental tenet of negotiation. Positions refers to outcomes that have been decided on, so it's the fixed thing that you want. Interests are what underlies that decision. So thinking about what broad outcome we hope to achieve, it may involve our underlying values in the situation. And there may be different pathways to get to this point, i.e. preserving our interests. So reframing problems in this way is an essential component of conflict resolution. And it's particularly beneficial when shared values and interests are identified. It helps to build relationships because we now have something in common that we can work together on. So all of the techniques and processes that I've described so far aim to do this. And what we do when we remind everyone, so this is, so my point here is that when we are taught to remind everyone that we're acting in the best interest of the patient when we encounter a difficult clinical scenario, this is essentially what we're doing. We're bringing it back to our shared interest of preserving patient care. I mentioned before that there's a lot of value in deconstructing the conflict, so breaking it down into manageable parts, and this was certainly important for people that often never thought about breaking it down before. We would spend time acknowledging the emotional and interpersonal component of the conflict. This needed to be done carefully, and an important part of the process was obviously to level the playing field, to account for different conflict management styles, different levels of assertiveness. We would account for some power imbalances in relationships as well. And then it was an opportunity to observe good communication practices. There is some evidence, and even in the health sector, that having an opportunity to participate in mediation would help to develop conflict skills in the future. So I've just lost my mouse, so I can't seem to change it.
I found it.
Where is it? Is it up there?
Yeah.
It's just waving around wildly.
He's got a cat.
No?
Show you the arrow keys.
Yeah, the arrows just worked. Has it changed slide? Yeah. That's my toddler. That is the predominant source of conflict in my life at the moment. So what I'm going to do now is talk a bit about some, as I said before, principles from conflict management theory that are applied in mediation that I think can be applied to conflict in healthcare, and that I think I've done in my years working in health. So, as has been drummed into me, working in medicine for many, many years, I think about most things now as a pre-event, the event, and post-event. It's a very exam way of thinking. But I do think that there is a lot of value in taking time to prepare for engaging in difficult conversations. We essentially need to acknowledge that there is a conflict in the first place, and then do what we can to optimise the environment. Obviously, a big caveat here is that it's not always possible if we have a disagreement about a time-critical safety issue, but often even a small amount of time can be taken to have a difficult conversation in a better way, such as having a better location, giving some time to calm down and reflect. And I've put a picture here of us, a simulation of us doing an RSI, where we've optimised the environment doing many simple things. Often time can be taken to do this in conflict as well. Appraising your own position is important, and this is something that I do try to do myself before I have these sorts of conversations. It's extremely difficult to negotiate and find a common solution when you have a fixed outcome in mind. So trying to consider what your overarching interests are can help you in entering the conversation. It's important to consider for something particularly challenging, you can talk to a colleague and get another perspective that can help reframe, identify biases and reality test. Obviously, in our situation, patient care is an important part of the preparation for conflict. It's a difficult balance because ideally we want to allow teams the opportunity to focus on providing patient care without the presence of conflict. But at the same time, we may need to address something that is directly affecting patient care, and finding that correct point can be challenging. So some of my thoughts about actually engaging with people from my experience. Much of the benefit was through the exploration of perspectives. So, as I said earlier, approaching with a spirit of genuine curiosity of the other person can help to explore their perspective and avoid falling into laying blame and assumptions about the person. And this should also apply to your own position as well, of course. So, for me, being curious about a perspective in a difficult conversation involves deep and sincere listening and a genuine interest in their perspective and really wanting to know what is driving it. Focusing on shared interests and values is extremely important. You can listen for these and take opportunities to identify them with the other person, and this can really help to move the discussion forward. Obviously, having something that you have in common, whatever that is, gives you something to work towards. And when I talk about modelling good communication practices, there's obvious things that everybody here knows about maintaining a calm tone and manner despite escalation. But I'm also talking about, I try to be mindful about blame and attribution and keep my conversations focused on direct facts. And then, like I said, I like to try to break down problems as much as I can to manageable parts. Lastly, one of the things that really struck me about having done that role was that sometimes an extremely minor issue or conflict can have a very big impact on somebody. Some of the most challenging ones that I dealt with would be neighbour disputes about a small thing like a fence, but it had escalated. And because it involves an issue with their neighbour, it involved an issue with how they felt safe and secure and at peace in their home. And this becomes a bit of a larger existential issue for people, and they become very distressed by the whole thing. So these would be very challenging issues to work through. So I guess the point that I'm trying to make is that everybody responds differently to conflict, and sometimes smaller conflicts may not seem like a big deal, but can cause a great deal of hurt in somebody else. The point I make here is that there can be value in thinking about a need for follow-on conversations and consider getting help. As I said, we say in mediation that the process is part of the product, so there is a value in talking things out. Even if you don't reach an agreement, we should take value in having direct conversations with people. And lastly, interpersonal conflict, from my experience in both mediation and in health, can be some of the most challenging things that we actually deal with in the workplace. Like any skill, conflict management takes practice, and it will be challenged when we encounter novel situations. So there's value in debriefing with somebody and receiving support. Another point that I want to make is the most challenging dispute that I managed in mediation was a healthcare dispute that involved extremely entrenched authority gradients that had been challenged due to concerns about patient safety. We had one group that was completely unwilling to accept feedback from another, and the other group was distressed that their concerns were not being addressed. So the issue we had was that this very entrenched culture made mediation impossible. We just couldn't bring them together because one side was not willing to receive feedback and the other was not willing to speak because they felt that they'd be punished. And the reason I bring this up is because despite all the things that we can do, we do need to have cultures that allow people to take interpersonal risks and speak up when they have concerns and try to address conflict in more manageable ways. This happens in health, of course. We all work in many different places where there's situations that are out of our control. But we do have some capacity to build relationships and foundations within our teams to try to prevent conflict or make it easier when it occurs. I've got a plug here for this concept of psychological safety. Claire talked about it in one of her talks recently, but there's been some great work done by Eve Purdy about psychological safety in ED teams. This is a very good Twitter thread on the topic, which has a link to a talk. Refers to the ability of members in a team to take interpersonal risks. And the interpersonal risks that I'm talking about here is, of course, the ability to speak up about something without being concerned about entering a conflict. People are very averse to conflict because it's stressful. So doing things to create these environments of speaking up is easier is expected to help improve conflict. Eve talks a bit about, she does acknowledge the challenge in environments like this about building a foundation for psychological safety because we work in ad hoc teams, we don't always get to know each other. So what she talks about are small moments that matter, things such as introductions and brief team briefings where we work to get everybody on the same page, understand roles, create priorities, and openly encourage people to speak up. And that's all I have. Thank you very much for listening.